So the first question for today is, describe the etiologies of non-immune hydrops. The first question is about non-immune hydrops, and secondly, what is going to be the evaluation of non-immune hydrops antenatally and then after the non-immune hydrops fetus has been delivered when it's a neonate. So the question is about how do I evaluate it. So everything about non-immune hydrops. Let us begin. So when I talk about non-immune hydrops, सबसे पहले तो मुझे हाइड्रोप्स फीटालिस क्या है इसको डिफाइन करना जरूरी है. So non-immune hydrops, question 1A. Always begin your answer, whatever be the question, by writing what is it about. So non-immune hydrops fetalis, and the first thing that you will do on mentioning the topic is going to be, you will be writing what is the definition. So non-immune hydrops is defined as the abnormal collection or accumulation of fluid in two or more than two spaces of body. So those spaces can be either your subcutaneous layer, it can be your pericardial cavity, it can be your peritoneal cavity, which is called as ascites, or it can be your pleural cavity. So either a char mein se, if there is a collection of fluid, clear fluid in any two of these four cavities, it is going to be called as having the fetus having hydrops. But remember that it is non-immune hydrops. So this collection has to be in a patient without red cell isoimmunization or alloimmunization. So without red cell alloimmunization. So the definition reads that it is the collection of fluid in two or more cavities of the body without any signs of red cell iso or alloimmunization. This happens to be 90% of the total cases of hydrops fetalis. Only 10% are the ones that are under immune hydrops fetalis because of red cell alloimmunization. So what can be the causes? Since they've asked me, the first question is about the etiologies. What can be the etiologies? So the etiologies can be varied. Plenty. I am going to enlist them one by one by the frequency of their occurrence. So my first cause is going to be cardiovascular thoracic causes, which are almost 20 to 30% of the cases. The most common cause being a cardiovascular cause. There can be many reasons, like there can be structural heart defects or structural congenital heart disease. A structural congenital heart disease can be anything like HLHS, that is hypoplastic left heart. It can be your tetralogy of Fallot. It can be your Ebstein's anomaly or atrioventricular septal defect, AVSD. So the first is going to be structural congenital heart disease. Second, there can be arrhythmias. In arrhythmias, you can have supraventricular tachycardia, you can have ventricular tachycardia, either of them. You can even have something like a heart block that is leading to this signs or to these signs of hydrops fetalis. Next, I have cardiomyopathies. In cardiomyopathies, I am also going to include myocarditis, viral myocarditis that you will see because of something called as Parvovirus B19 as well. So it can be because of some cardiomyopathy that the fetus has, most common being hypertrophic cardiomyopathy that the fetus can have, and also myocarditis. The next common cause is going to be chromosomal abnormality. By the way, if you ask me, why should CVS or any structural cardiac abnormality lead to should it lead to hydrops fetalis? Remember, whenever there is any problem with the cardiac diastole or systole, it can lead to signs of heart failure. This heart failure is basically the heart unable to relax, that is, have a good diastole, or be able to contract, that is, a good systole. This leads to back pressure changes like congestive cardiac failure that you read in adults. These back pressure changes are going to be the one that lead to multiple signs of what do we say, of back pressure changes leading to venous stasis, extravasation of fluid, third space loss, hepatic failure. All these things are because of the cardiac cause of edema. Just a second. Yeah. Next it is going to be chromosomal abnormalities. So when I talk about chromosomal abnormalities, it can be anything. It can be trisomy 21, that is Down syndrome. It can be trisomy 18, that is Edwards syndrome. It can be Patau syndrome, trisomy 13, or it can even occasionally be Turner syndrome, which we also call as monosomy X or XO phenotype, genotype. In chromosomal abnormalities, invariably there is going to be some or the other defect with the heart and with several other structures in the body as well. But most importantly, your heart is going to have some or the other cardiac defect, like trisomy 21 is going to have AVSD. Trisomy 18 might have something like TGA, transposition of great arteries. There are many things that can happen that can go wrong. Turner's is going to have coarctation of aorta. All these things are going to lead to the heart having the same thing that happened in the CVS part that we read, back pressure changes, and that will eventually lead to congestive heart failure and edema in various aspects of the body. Next that I have are going to be hematological disorders, but non-alloimmunization wale. Hematological disorders, but ones that are not because of red cell alloimmunization. So what can they be? It can be something like alpha or beta thalassemia major, mostly alpha thalassemia major, which is going to be lethal in utero only because of hydrops fetalis. The fetus succumbs. The fetus is not able to survive. Now, in this, there are no antibodies that are destroying. The cells are having a poor hemoglobin, and that poor hemoglobin cell is going to have defects in it, which are going to be diagnosed or detected by the reticuloendothelial system of the body, and they are going to be destroyed. Basically, there is also going to be severe anemia because the cells that are being produced are not normal. The hemoglobin is not normal, so the fetal hemoglobin is not able to carry oxygen. When it is not able to carry oxygen, there is going to be high output cardiac failure that will lead to beta thalassemia, leading to severe anemia and then heart failure. Apart from that, if you have anything like feto-maternal hemorrhage, if you have twin transfusion syndrome in monochorionic pregnancies, or if you have anemia because of other causes. What other causes? It can be most commonly Parvovirus B19 infection, or it can be because of something called as a diamond black fan anemia. Basically, even your erythroid precursors are going to be destroyed in this, and that will lead to you having severe anemia. This severe anemia is going to pose a lot of pressure or stress on your heart, leading to signs of cardiac heart failure. Next, you have thoracic abnormalities. When I talk about thoracic abnormalities, what is going to happen? An example, if I'm to give you, is going to be congenital cystic adenoid malformation or pulmonary sequestration. There is also something called as a chaos, that is congenital high airway obstructive sequence. इसमें क्या होता है? In congenital high airway obstructive sequence, imagine there is something like a tracheal atresia. Basically, your trachea is obstructed. There is something in the higher airway tract. Higher airway can be a bronchus or your trachea or your upper tract pharynx. There is some obstruction. Now, your lungs in your in utero life produce a lot of fluid, and that lot of fluid is going to be come out through your mouth. So when it comes out through your mouth, it forms a fluid that is around it, the amniotic cavity. Amniotic fluid is going to be formed because of that. Now remember that whenever this happens, there is a continuous circulation that it is being produced in the lungs and then it is being thrown out. But if there is any obstruction to this outflow tract in the lungs, that is called as congenital high airway sequence, this fluid is going to be accumulated in your lungs. This accumulation in your lungs makes your lungs very enlarged. They swell up completely. This swelling is going to compress your compressible vessels in the chest. They happen to be your IVC and SVC. अगर IVC SVC block हो गए, so remember the back pressure changes will start again, and there is going to be there are going to be signs of fetal hydrop. So remember, chaos sequence. Congenital cystic adenoid malformation, again, there is a part of lung that is maldeveloped. It has very dysplastic lung parenchyma, whereas in pulmonary sequestration, a normal lung segment is completely being created away from the lung field in the thorax, but away from the normal lung field. So all these causes can lead to thoracic compression on the vena cavas, and that will lead to eventually your signs of hydrops fetalis. Apart from that, if there are any mediastinal tumors that compress the SVC and IVC, even they can cause the same, or any lymphatic malformation which leads to a swelling in the chest. Next, you have proper lymphatic abnormalities itself. Those lymphatic abnormalities can be are going to be either congenital lymphectasia. Basically, there is ectasia or stasis of lymph leading to large swelling that leads to compression of the vena cava, or there can be something like cystic hydroma, in which the jugular sacs are going to be quite enlarged. Next, I have infections. Now, what do infections do? Now, remember that these infections, which include your torch infection and parvovirus, you will hear this word a lot of times today. So, parvovirus B19. What this does is they go and affect the fetal liver and spleen. Now, your fetal liver and spleen are main organs of hematopoiesis in your intrauterine life. Remember, your intrauterine hematopoiesis is always extramedullary. So whenever it is going to be extramedullary, remember that if there is anything that affects this organ or these organs, the liver and spleen, this hematopoiesis is going to reduce. Also, your liver produces your proteins. In the fetus, the protein, just like in adults, it is the albumin. In the fetus, it is going to be alpha fetoprotein. So उसका भी बनने का कम हो जाएगा quantity. So basically your hematopoiesis is shut down, your protein production is shut down. So basically your anemia is going to start occurring क्योंकि hematopoiesis नहीं हो रहा है. Apart from that, your vessels oncotic pressure because of the proteins in them is going to reduce because proteins are not being produced. So because of this hepatic dysfunction, there is a cycle that is being set off that will eventually precipitate in hydrops fetalis. So these infections are capable of doing that. Parvovirus B19 goes and destroys all your precursors, especially in your bone marrow, in your intrauterine life. It destroys all the precursors, the erythroblasts, and that is why this anemia is going to be very severe. Next, I have metabolic disorders. Metabolic disorders again are going to cause hepatic dysfunction. They can be lysosomal storage disorders or glycogen storage disorders. Again, the hepatocytes are going to be damaged. And you can also have paroxysmal or paroxysmal disorders, storage disorders. So all these are going to lead to hepatic dysfunction. Next, you can have some placental abnormality. What placental abnormality? Something like a chorangioma. What is a chorangioma? A chorangioma is a tumor of the placental vessels on the chorionic surface. So basically, there is a large vascular tumor that is growing on your placenta, and that tumor is also now going to be supplied by the fetus. So now this fetus has to supply a completely new entity which is taking up a lot of its blood supply. So the heart of that fetus has to overfunction to not just supply its own body but also that tumor that is growing in the placenta. This leads to high output cardiac failure. Basically, the heart is overworking, and this overworking tires the heart out, and that leads to heart failure. So placental abnormalities are going to lead to this problem in chorangioma. It is going to lead to hydrops fetalis. Next, I can have genetic problems, genetic disorders like Noonan syndrome, Costello syndrome, achondrogenesis, several, many of them. You will ask me, how is achondroplasia going to cause hydrops fetalis? Remember, achondroplasia is where the cartilage is not being formed well. So the lung, the costal cartilage is not going to be formed well enough, and my thorax is not going to develop that well. So the fetal thorax is not developing well enough, and that fetal thorax, if it doesn't develop well enough, it will lead to pulmonary hypoplasia. That pulmonary hypoplasia is going to compress all these structures that are trapped within the thorax are going to compress upon the superior vena cava, inferior vena cava, and that will lead to back pressure changes and hydrops fetalis. And then the last one is going to be, of course, idiopathic, wherein I absolutely do not know the cause despite the entire evaluation being undertaken. So these are all the causes of hydrops fetalis